English if you don't mind. Okay, so. Okay, so প্রথমে শুরুতে just a light-hearted introduction to evidence-based medicine. আমি আপনাদেরকে একটা short video দেখাই। The video actually আপনার জন্য interesting হবে. The person who's done this video is actually a professor of pharmacology in America. So he's very much into evidence-based medicine. So it is just আপনাকে একটা basic introduction there on evidence-based medicine. So videoটা দেখেন। So that's just a very brief overview of what we are going to talk about today. So the learning objectives of this session is that I'm going to briefly touch upon why we need evidence-based medicine, bit of historical background and the steps of evidence-based medicine. So from the, if we start from the Bangladesh perspective, we all have come across this, growing up in Bangladesh. আমরা জানি যে আমাদের রোগীরা অনেকেই পীর মাজার পানি পড়া এগুলো বিশ্বাস করে। পেপারে প্রায় দেখা যায় যে ডায়াবেটিসের জন্য কোনো পীর ম্যাজিক কিওর অফার করতেছে, অথবা কেউ ঘুমের মধ্যে স্বপ্ন দেখে কোনো চিকিৎসা পাইছে ইয়ে হয়, এবং মানুষ এগুলোর জন্য হাজার হাজার টাকা খরচ করে। আমার নিজের আব্বা তার ডায়াবেটিসের চিকিৎসার জন্য এরকম পেপারে কোন পীরের খবর দেখে সেখানে চলে গেছিল একবার, আমি তখন মেডিকেল স্টুডেন্ট। তো এরকম হচ্ছে অবস্থা। তো in this perspective, if you think that এই জিনিসগুলো শুধু বাংলাদেশে হয় because we are an underdeveloped country, আমাদের literacy rate very poor and people are not understanding, then you won't be completely wrong. Because I can tell you that this is America 100 years back. You won't believe that 100 years, not even 100 years. I mean, this is talking about, less than 100 years back in America. People used to believe that a treatment for male impotence is to have goat testicle implant. And so you cannot even believe this child is apparently somebody conceived a child after implanting a goat testicle. So that's the level of, how gullible people can be. You may have heard of this term, which is known as snake oil salesman. And this is, again, it came from America because less than 100 years back, they used to sell rattlesnake oil in America, and they used to tout it as the cure for all ailments, and people used to buy it. So that's American perspective. What about UK? So our current king, you will not believe, our king is the patron of the UK homeopathy group. And as we all know, scientifically it's proved that in homeopathy, the fluid is so diluted that there is absolutely no active chemical substance in it. But still, even somebody as important as the ex-prince, and now he's the king, King Charles believes that homeopathy works, to the point that he is happy to become the chief patron of the UK Homeopathy Association. And then, recently there was a very famous eye surgeon here in UK who was struck off because it was found that he was giving unnecessary eye implants. Again, he would tell patients that, oh, this make you better, and then they would have it. So what this background tells us that our patients are often desperate, and they will do anything to get better. It will also tell you that patients generally, they trust doctors or a healthcare professional, and there are a lot of unscrupulous people out there who are going to take this opportunity. So on the basis of these, what is the relevant evidence for practice of medicine? So this study is actually now quite old, but I don't think there's been any relevant study since then. The study was done by Richard Smith, who is the ex-editor of BMJ. Found 1991, found that only 15% of all medical interventions are supported by solid scientific evidence. Only 15%. And then a few years later, BMJ did another study, the follow-on really, and this is a medical student from America who was saying that essentially said, okay, so we do things, as in, we treat patients or something, but why are we doing this particular treatment? So as you can see, it's the same thing in Bangladesh. It's exactly the same. We said this because our teachers said so, or we were forced by them, or sometimes the patients force us, or you get some incentives from pharmaceutical companies. Excuse me, I'm sure all of you are familiar with it. Or because of the fear of the legal system, especially, for me, this is a big thing here in UK. We're always scared of being sued. So everything we do, the first thing I think is, am I going to be sued if I do this? So sometimes you do over-treatment purely just to, save your skin. So the bottom line is there are lots of reasons for offering a medical treatment, but because this treatment is supported by solid scientific evidence, it's not there. Okay. Now, the issue is obviously, there are two ways of looking at it. One is you do a treatment because you think in good sense or in good faith it works. So you do it and it may not work. And if it doesn't work and if it's harmless, then okay, it's not a big deal. You've given a treatment, it's not worked, you did it in your best faith or something, okay. The problem is if a treatment you give to the patient, untreated treatments can actually be deadly, can kill patients. And this is one of the best examples of that. So, so again, quite a few, I mean, looking about 30, 40 years back, a treatment, they started giving treatment for patients who would present with acute cardiac arrhythmia with antiarrhythmic drugs. So the idea, and it makes sense, patients got arrhythmia, so you straight away give them antiarrhythmic drugs to try to stop the arrhythmia. But people, this came from basic studies that the antiarrhythmic drugs reduce arrhythmia. But it didn't actually look at the ultimate outcome. What happened to the patient? Is the patient alive, or did it stop it from developing an MI or a actual fatal cardiac event? Then came this landmark trial. This is known as the CUST trial, and they actually found that in the CUST trial that if you gave patients antiarrhythmic compared to placebo, the mortality rate was higher with antiarrhythmic. So we were offering patients a treatment in best belief, physiologically it makes sense, but nobody actually looked at the ultimate outcome. And so you were killing lots of patients, and it's actually estimated that by the time, this drug had been tested and it proven that acute arrhythmia, you shouldn't be giving it. Thousands of people had actually died. So this is why it's important to understand the importance of offering a treatment which is supported by evidence. So we hear about this evidence-based medicine, this word all the time. What does it actually mean? So this is the best definition of evidence-based medicine. It was proposed by Dave Sackett from Oxford. Again, in the 90s, he says, the reason for giving a definition is because when you think about evidence-based medicine, people think, we have to give evidence, that's it. So, but actually, in practical life, evidence is not everything. So you have to be more pragmatic and you have to take other things in consideration. And what this definition does is actually makes it explicit to you what else you need to look at. So here's the definition, as you can see. Evidence-based medicine is the integration of best research evidence with expertise and patient values. And then a few years later, the evidence people who are in the forefront of this evidence-based medicine movement, they came together in Sicily and made a formal statement where they said, evidence-based practice requires that decisions about healthcare are based on the best available, which means it's got to be current, valid, and relevant evidence. So that's how you get the best evidence. It's got to be current. It's not something like 20 years old. It's got to be valid, where you actually find that it's real evidence and it's relevant for your patient. Then these decisions should be made by those receiving care. And this is very important. And this is not something that we still practice in Bangladesh, because our patients are not really educated, not educated, but educated in the values of different treatment options. So they expect you to make the decision for them, and that's just a reality. But this is the ideal situation where you take the patient through the journey. We call it a patient journey, and in the West here, we use the word, it's called shared decision making. So when I see a patient and I put patient to the list, I always dictate and I put in my letter that I've discussed the options, pros and cons of different options, and then we both jointly agreed that this is the treatment we're going to do. And then, so this is the thing, is that this decision, that when the patient makes the decision should be informed, we call it an informed decision making. So there should be a tacit and explicit knowledge of those providing care, yeah? So that means you, as the physician, offer both the pros and cons of different treatment options to the patient, and you can recommend an option, but let the patient make the decision for you. Within the context, and that's also important, within the context of available resources. So there is no point, making a decision for a treatment which is unaffordable for the patient or the society in general. So these are the 3 steps. So to recap, these are the 3 steps of evidence-based medicine. So what have we got here? Step number 1, it said best external evidence. So remember, the term is the best external evidence. Again, when we think about evidence, a common mistake is to think that we have to have an RCT. Without an RCT, there's no evidence. Well, that doesn't make sense. Because if there's no RCT, you first of all, if you're looking for an intervention, for example, yeah, you look for an RCT. But if there's no RCT, then we go down the ladder, see what is the next available best option. If that's not there, then go to the next. And then you say, okay, this is the best evidence we found. The quality of evidence is not great, but this is the best one. So it's got to be your best external evidence, whatever you got. So, and this is just a pyramid filter of evidence to give you an idea what can happen. So as you can see, at the very bottom rung is the expert opinion. We call it a grade 5 evidence. So essentially, and this is not something, okay, it might sound like a poo-poo as a low quality evidence, but actually it's also important. So your colleagues who has been treating patients for 20 years or 30 years would have had over the years developed a certain expertise and would be able to tell what works or what does not work in his or her experience. And that's something can also be important in instances where you do not have better quality evidence. So that's your expert opinion, grade 5 quality evidence. So sometimes you may have better information, which is basically you could have a case report for one particular case, something very extraordinary, or you could have a case series involving a few cases. And then you could have a cohort studies where the patients, usually case series would usually be retrospective when patients have been looked backwards and seen their results, or it could be a prospective cohort where a group of patients with a particular illness have been, have been followed up prospectively over a period of time. So the quality of information is better. You knew what you were looking for and what primary and secondary outcome you're interested in. So you documented them from day one. So you just get a better quality evidence. And then the next comes your randomized control trial. So randomized control trial is very good for studies looking at interventions. But your question, your clinical question may not be intervention always. I mean, it could be a diagnostic question. So only when it's a therapeutic question that you'll be looking for a randomized control trial. In other instances, it will not be appropriate. So these are basically primary evidences which are unfiltered that you will find. But more importantly, when you are practicing evidence-based medicine and is purely being pragmatic and practical and to save time, you may not always, and you will not always have time to look at primary evidence and appraise it for yourself. So you may not have time to look through all the RCTs or cohort studies. And then the smart thing to do is to look at filtered quality evidence. So you may get critically appraised articles, or more importantly, systematic reviews. So systematic reviews, they lie at the very top of this evidence pyramid. So you look for systematic review, and if you find it for a particular problem, then you know that that's what the evidence you're looking for. So that is our best quality evidence. And the next thing important is to look at the individual clinical expertise. And this is also important. Remember, you may find that for one particular illness or something, this particular drug or even a surgery is useful. But you may not have somebody in your locality who has the expertise of that. So then you have to be pragmatic and practical and come down the rudder. So okay, we don't have, this might be the best quality evidence, but we don't have the expertise. So what within our expertise, what is it that we can offer for our patient? And the final thing is patients' values and expectations. So you have to, this is probably what is more important for me to emphasize for you guys, because we have not developed this culture in Bangladesh as yet. And I think we as the country moves forward, develops more, the economy gets bigger, and people start interacting more with the West and with the outside world, I think the values would change, the expectation would change. And so it's probably best to remain at the forefront of it. which is you discuss the option and you respect patients' values and expectations. So a common example I give to my patients when I do the course about this is about red wine. So I don't know if you guys know, but there is good quality evidence that if you drink red wine in moderation, and the word is moderation, not heavy drinking, then it does have a certain amount of cardiovascular protective effect. Well, the point is, so the evidence is there, and there is no question about it. But are you going to advise a patient who has, cardiovascular morbidity to you, a Muslim guy, if I go to my GP, is he going to offer me red wine or advise me, oh, you should drink red wine regularly? Well, it's not going to, it's not going to fit with my Islamic values. It's not going to work. For non-Muslim, it's fine, but for me, it's not going to work, isn't it? So you've got to respect patients' values and expectations as well. So that is what we are looking for while we are practicing evidence-based medicine. So as you can see, point number 2 and 3 is subjective. We can look at it. The main objective issue is to get the quality of information so you can make the right healthcare decision for your patient. What works or what doesn't work. So when we are looking for this quality of information, what we need, as the Sicily statement says, is that we need up-to-date, reliable, and relevant research findings. And remember, the problem is the evidence is so, so broad, and there is so much of evidence. It's seldom there is time for anyone to remain up-to-date with everything. So the best thing is you need evidence in primary form. Yes, there's no question about it, and that is what is going to be published in research journals. But you also need in a summary form, which is easily available for the average practicing physicians. Remember, we're not talking about academics here who have got a lot of time. I mean, all of you are academics, so your situation is different, but we're talking about generally from the perspective of the practicing physician who ideally needs it in a summary form. And this is where the problem comes. There is a large gap between research evidence and clinical practice. So to keep up to date, you really need to be reading hundreds of articles a day, and that's just not possible, is it? On top of that, this is Dave Sackett, who was the guru of evidence-based medicine in Oxford, and he did an interesting study, looked at how much time people at different stages of training spend behind reading medical journals. As you can see, he didn't even look at consultants because we don't have time, and I don't know the last time I actually really went to a journal properly. But the medical student, when you're a medical student, back home they might not be reading, but here they're very keen. So they're up to date, so they'll go there and say, "Oh, I'll read it." So this is, I think, weekly, yeah, time spent in a week, medical students. And as you go up the ladder, as you can see, the more senior you get, the time actually gets less and less. And consultants, hardly anything. So we need to be able to use the evidence efficiently. So as you can see, the number of journals and number of articles published per day, per year is just absolutely massive. It's just impossible for anybody to keep track of everything. And so what you need is a way to be more efficiently able to assess or access this information. So what do you do is obviously, ideally, you should be reading it, but more importantly, what you do, you seek and apply evidence-based medical summaries, which can be generated by others. So this brings me to the 5S approach to practicing evidence-based medicine. So that's what you do. What do you do? Excuse me. So yeah, you look for primary studies, but the next option, even better, is to look for systematic reviews. And if you get lots of systematic reviews, then you look for synopses. If you have lots of synopses, you look for summaries, and there are summaries, then there are even computerized decision-making support systems. So these are the 5S levels of approaching EBM: studies, synthesis, synopsis, summaries, systems. So don't confuse it with the evidence pyramid. Remember, with the evidence pyramid, systematic review lies at the very top of evidence pyramid, which is the quality of the primary evidence. But then when we talk about the 5S approach, there is, synopsis comes on top of systematic reviews. So lots of systematic reviews, then you summarize them into evidence-based journal abstracts in synopsis. And then you can summarize those synopses and write evidence-based textbooks, or there might be computerized decision-making tools available as well. Okay, so there are like examples of lots of books now you will get where there are evidence-based summaries of what works or does not work for different treatment options. You can go to this database, which is known as TRIP database. You will find it in online. TRIP stands for Turning Research into Practice. So if you put a question in the search window in the TRIP database, it will bring you with answer, and it actually tells you, as you can see, what type of evidence you have found. So here was looking at neuroamidase inhibitor for influenza. You got so quite a few papers, and it's showing you got evidence-based synopsis. There are no evidence-based synopsis or systematic reviews, the clinical question answers, and extended primary research. So then you got an idea of what you are getting. You can also, the other place to go for is BMJ. If you go to BMJ website, there is a separate sister website which is known as Clinical Evidence, and you will find lots of answers, as you can see, and it regularly gives you reviews. Helicobacter pylori infection, herpes labialis, hepatitis B, gastroenteritis in children, or whatever, what to do. So you'll get those answers there. And finally, you can go into Cochrane collaboration. So Cochrane is, they have a website now, essentially a group of academics here in the UK gathered together about 30, 40 years back again, and got some grant from the government. So they built this collaborative academic system where they were summarizing, looking at the quality of evidence and summarizing it. So Cochrane has now grown into quite a large body. There are hundreds, if not thousands, of systematic reviews there. They will only look at good quality evidence. So only they will summarize RCTs. So it's really looking at intervention, but you should be able to access Cochrane collaboration website. And I suspect, as a underdeveloped country, for anybody with internet protocol address from Bangladesh, it might be free for you guys. For me, from the UK, it's free because the UK government subscribes to it for us. So anybody accessing this from UK, you'll be able to access it for free. Go to Cochrane Collaboration website. So this is like that. You have a separate Cochrane library, or again, a separate website where you get all these different questions, and you got a separate page for Cochrane reviews, a Cochrane library, which will also host evidence which is not only generated by the Cochrane reviews, but from other reviews as well. Okay, so that really is a summary of what I wanted to talk to you about evidence-based medicine. So let's have a bit of an example. Say that, for example, as a clinician, you have a clinical problems. Okay. So if you have a clinical problem, you're asking. So as you can see, this is the orange oval. So you have a clinical problem and you are here. Now, so you want to find out what is the best evidence for your patient. So the clinical question that you have could be of 4 times. It could be related to etiology. So let's say COVID-19. So etiology, maybe you are interested in finding out the causes of COVID-19, or diagnostic, how best to diagnose COVID-19, or prognostic. What is the prognosis for somebody in their 60s with diabetes who catches a COVID-19, or it could be therapeutic. What is the best treatment for this patient who has COVID-19 with diabetes? So these different type of clinical questions will generate different types of clinical queries. Will generate different types of clinical questions. And so you need to look at different types of studies. So if your issue was related to therapeutic question, what is the best treatment, then you're going to look for a randomized control trial. If it is etiology, you may want to look at observational, case control study or retrospective study. If it's prognostic, you may be looking at a case control study. Or if there's nothing else, you might be looking at a case series or case report. Or if you're lucky, you might even have a systematic review. Excuse me. Okay. So these are the different types of qualitative evidence that might be there for you to find your evidence. So then what you do is, with your clinical question, then you will formulate a clinical question, and ideally, we will come to it, but ideally you should be formulating it in a PICO format. And we will talk about PICO in a minute. It's just that it gives a structure to the question and makes it easy for the search engine to look for evidence for you. But it doesn't have to be PICO. You can even put free text search. For example, you can just put free text search in Google and you just write, what is the best treatment for COVID for somebody in their 60s with diabetes? It will give you the answer. And then you search the database for your evidence. And ideally, you need to search multiple databases. For example, I'm sure many of us just simply go to Google, which is okay, not bad, but you may not get good quality evidence there. So then, if, for example, as we say, if you are looking at randomized controlled trial, then it's best to go to the Cochrane database. Or if you're looking, if it's a case control or retrospective, is not going to be there in Cochrane. But you should ideally look for a number of databases. And the biggest one we use is PubMed, of course. Then if you do not have a summary of your primary evidence, then you have to take the initiative and do a little bit of critical appraisal. Because remember, whatever is written does not necessarily mean that it's true, and there might be some, caveats in it. So you need to try and decide whether, excuse me, whether what you read is true or not. Okay. So then you will look at appraise those evidence and apply it. So as we said again, how do you look for evidence? It depends on whether your clinical question is related to intervention or other. If it's an intervention, simplest option is to go to Cochrane Library and look at Cochrane systematic review. And if you have it, don't waste your time looking for anything else. That's the best quality evidence there. If there's no Cochrane systematic review, then there are other databases. There is one database, or Central is another database. Then you look for it. And if you find the evidence, you're happy with it. If there is no systematic review, then you need to try and do some kind of critical appraisal, which is the main part of practicing evidence-based medicine here. If there are no RCTs, then by all means go to PubMed queries. Then you look if there's anything there in PubMed query. Okay. In summary, the process of practicing evidence-based medicine is like this. So you, as a clinician, you have a patient in front of you who has a dilemma. Okay. And then you ask yourself a question. Once you ask the question, you go to the database and you acquire the evidence for the question. Once you acquire the question, you try and appraise it. You look at the hierarchy of evidence to see what is the quality of evidence you're dealing with here. And then you apply it. You have to make a considered judgment whether this is applicable to your patient or not. You apply it. And so that is act and assess. So these are the, we looked at previously, we looked at the 5 stages of evidence. And now we're looking at the process of evidence-based practice, which is basically the 6A. So ask, acquire, appraise, apply, act, and assess. So I'll go through again. So you got ask, acquire, appraise, apply, act, and assess. So here is an example. I'm a non-smoker. I don't have diabetes. I don't have hypertension, but my cholesterol level is high. I've not had an MI before. So my GP put me on statin. I'm actually on quite a high dose of statins compared to people in Bangladesh. I'm taking 40 milligrams of atorvastatin a day. And so the reason for taking this drug is primary prevention of MI. Okay. The issue is, so I might have this clinical question: what is the effectiveness of statin to act as a primary prevention of MI? Remember, it's not secondary. In a patient, in their 50s, otherwise fit and well, just a little bit of cholesterol. And then you'll find the evidence. So when you get the evidence, so the number we have to deal with are NNT, which is the number needed to treat. And this is something we will discuss on day 2 if we get there tomorrow. So essentially, it's about less than 10% reduction in risk of having MI. Then the question is, this is for you to decide. So what I'm showing is practical example. So even if you get the evidence, and this is good quality evidence, so we know. So in a patient like this, having a statin reduces the risk of having a primary MI by 10%. Then you consider all the risk of taking statins for God knows how many years, and then you have to decide, is it really worth it or not? That's how we apply. So if I wanted to make a structured clinical query, this is how I'm going to put it. As I said, we discussed the PICO format. So PICO, P is a patient. So in a patient with low to medium risk, I is the intervention, the treatment with statins. So C is your comparison compared to placebo, and the outcome is prevent cardiovascular death. So that's how you put the question, and then you search. So this is our search results. So as you can see, luckily we found this. So it's basically again a systematic review. So systematic review, they say that's it. So reduce the risk, 5-year risk less than 10% if you treat it in 5 years. Yeah. And then your statin therapy, there's an 18% risk of causing side effects. So then you have to decide, is it really worth giving it or not? And so that's the next stage. So first of all, we were talking about getting the best quality evidence. But then the question is, you appraise the evidence and then you assess, is it actually applicable for your patient or not? So if, for example, if a patient came to me like mid-80s, or it is not unheard of, even here in the UK, sometimes our GPs would put a patient, because the evidence is there, an 80-year-old lady or a 90-year-old lady on statins. There's absolutely no point, because it's less than 10% reduction in risk. Whereas it will cause all sorts of side effects in that patient. So you have to make that judgment. You have to make that judgment. What does it mean for my immediate patient? Remember, the result, whatever the result is there, that's an average result. That works well for average, but for individual patients may not be applicable. Then you need to look at your patient and decide, does it actually work for my patient or not? Somebody like me in the mid-50s, it may make sense. But does it actually make sense for somebody in their 90s or not? So that's one aspect of it. So the other important thing, as we say, is that unfortunately you will not always have evidence which has been appraised. Then you have to appraise it, and this is important. As we know, we've all been taught this from our youth, that all that glitters is not gold, which means, so again, it applies for journal articles as well. Because whatever is written does not necessarily mean is valid. So you have to be able to judge it for yourself. And this is where the question of critical appraisal comes. This is a statement from BMJ a few years back, which says that a 21st century clinician who cannot critically read a study is as unprepared as one who cannot take a blood pressure or examine the cardiovascular system. The point is, you have to have some amount of critical appraisal skill so that you can be in a position to decide for yourself what works and what does not work. Okay. So in summary, the 5 steps of evidence-based medicine is that you have a clinical dilemma, you formulate an answerable question, you track down the best evidence, you critically appraise them for valid. You critically appraise the evidence for validity or clinical relevance, and then you have to individualize based on your clinical expertise as well as patient concern. And obviously you have to, keep on evaluating on a regular basis. So that's really all I wanted to talk about. Just something, to give you some points for thinking is that what is interesting is that we talk about best quality of business and everything, but there is very good evidence from psychology that there is a thing called cognitive bias, which affects our judgment all the time. Essentially, cognitive bias is that your mind will distort your own view of reality to adjust to whatever your belief is. Okay, so this is also known as bandwagon effect or confirmation bias, motivated reasoning. And so, which is basically, it does not really matter whatever evidence there is, you will still continue to do whatever you believe is the right thing. So you will make some kind of argument inside your mind to justify yourself. And they say that because the reason is people cannot live with things which they don't agree with. So that's why the mind plays a trick. For example, a murderer or even a thief has a justification in their mind for doing the theft or doing that murder. Otherwise, their mind will not be able to, they will get mad. Okay. So I think that's all I wanted to talk to you about today. So I'm going to finish with another video from James McCormack, which basically more or less summarizes what we, say. So the bottom line is, do not follow the guidelines blindly. Okay, so that's it. So I'm going to open up the floor now. I don't know, is Pradipda, is he in now? Pradipda?
Yes, I'm here. Sorry that I joined it a little bit late.
No, it's okay.
Because there was a lot
Yeah.
of electricity failure in Dhaka right now.
Okay. We're getting late, so we didn't want to, keep people waiting for too long. So
No, it's okay.
So I'm happy to open up the floor now for discussion. Dada, do you want to moderate that now?
Yes, anybody can ask any question to Dr. Monir Hussain, and he's happy to answer your question. Although I understand that the lecture was very much interesting and he didn't go elaborately all the terms. Some terms may be unfamiliar with some of our attendees. So even though if you have any question, you can ask him, and I believe he will answer your question. আপনারা নিজেরা জাস্ট ইন্ট্রোডাকশন দিয়ে আপনারা প্রশ্ন করতে পারেন, কাউকে রাখতে চাচ্ছি না আমরা।
Yes, sir. Thank you. May I have?
Can I ask one question?
Yes, please, madam.
Yeah, thank you very much for your nice lecture. At the beginning of your lecture, you told about this EBM, that is evidence-based medicine of Bangladesh perspective. So, what do you think? The doctors here in Bangladesh, they're practicing. Yeah, so many doctors are practicing. So, what do you think here, this evidence-based medicine is how or in which extent it is practiced?
So I missed your last line. Sorry. What do I think?
Yeah, in Bangladesh, up to which extent this evidence-based medicine is being practiced by the doctors who actually do the practices, actually do the business with the patient.
Okay. So the truth is, Appa, I mean, it's probably very unfair for me to say how or why, I should be done in Bangladesh, because the truth is, I don't practice medicine in Bangladesh, and I never have. I left immediately after my internship. So that's the whole point of having this discussion. Is I wanted to. This is not like a teaching session. This is more like an interactive session, sharing of experience. I wanted to share with you what is the gold standard in the West, where we've been practicing evidence-based medicine movement for some time, how it is. The reality is, in a perspective of Bangladesh, it is not easy, it's difficult, but I am pretty sure people who are interested can start the process. So when you start a process, when you are a pioneer in something, it's always going to be difficult. Remember, we talked about the patient's values and expectations, and I am pretty sure in Bangladesh, if you give patients 5 options for a particular treatment and say that, look, we can do this or this or that, and these are the pros and cons, what do you want? What do you think? Patient will say, oh, this doctor has no confidence on the treatment options. Why is he asking me to do it? So the culture is not there. So it's not going to be easy. So I do not want to be prescriptive as to how or what should be done in Bangladesh. And all of you who are, currently practicing in Bangladesh are actually much better placed to comment on the prospect of doing it in Bangladesh. The idea was to just share my experience with you.
But you have been starting in your talk. You have been told us that in Bangladesh we have Panikora, fears, so many things. So that's why I thought you have
that is just the reality of what happens. But what I said is that it's not, if you think that this happens in Bangladesh, that's not true. Because the same thing happens in America and here in UK as well, because that's why we have our king, who is the patron of homeopathic medicine, which doesn't work.
Yes, sir. Thank you very much for arranging this session. And I must congratulate Dr. Monir for giving this such elaborative and interesting topic, actually. I have 2 or 3 clarification I need from him. One is that it actually best fit for the clinical decision making that is mainly practiced by the clinician. if am I right, then I want to ask you to just explain some of the cognitive bias. You have mentioned that term. So if you can explain a little bit, that will be very easy. Another thing that in the presentation, I found that regarding statin, you have discouraged, or there is some evidence to discourage regarding those the low risk people. So how we can identify this who to whom we will prescribe this or to whom we will not prescribe? If you can explain a little bit more, that will be helpful for us. And third point, that is this evidence-based medicines is, I think, basically for the clinicians, but how it can be utilized by the public health people. That's enough.
Thank you, sir. Yes, I mean, when we talk about evidence-based medicine, it's mainly, I mean, it's probably also because I am, I am come from a clinical background. So we talk about, doing it from the clinical perspective. I think, yes, so to answer directly to your last question, for public health, the issue, it can be applicable for public health people as well. The issue is, for example, what kind of community interventions can you do to improve public health? For example, in a particular community, with how can you improve maternal mortality? How can you improve, child health mortality? Or if an intervention is being done, then to see again, and there are randomized control trials on these aspects to see whether these make any difference or not. So it might be that you introduce, for example, a midwife going to, pregnant women's houses weekly. You start this intervention, and then you don't know whether this actually improved maternal mortality or childhood mortality in the end or not. And then you can do a randomized control trial on it, and there are papers being published on that. So that's how the child health people can, public health people can, utilize their evidence-based medicine. The other obvious place for public health medicine people to be involved is on the diagnostic side. The sensitivity and specificity of different diagnostic tests, which is a big thing for in the public health field. So. About the statins, I did not actually discourage. What I was saying is that I was just giving an example from my personal side. I wouldn't be discouraging it, because if I was going to discourage, remember, I am a low to medium risk, but I've been having it for years now. How many years? I don't know, 10 years or something. So I was not discouraging it as who to prescribe. I mean, this is what I am saying is that I do not want to be prescriptive, but if you follow the template of evidence-based medicine, what it actually says, that if you have a patient in front of you who is coming with, and you are thinking that this patient has got high cholesterol, I want to prescribe statins, then ideally, if you want to practice evidence-based medicine, the steps to follow is that, first of all, you find out what is the level of risk for this patient. And then you go and do a bit of a search and find out what is the level of risk this patient has of having, for example, MI. That's what you're interested in. And then you find what is there in the literature as to, if you give statin to a patient of this amount of risk, what is going to be the benefits and the risks. And then ideally, and then you should lay this all out to the patient. I said, look, so you tell the patient, look, I can give you statins. The idea is it will reduce your cholesterol level. It will reduce your cholesterol, but there is about this amount of chance that, you might still have an MI. It will reduce it by this much, and these are the risks. So this is what the ideal scenario. I'm not saying that scenario will be applicable completely in Bangladesh, and you may have to modify it, and you're probably working in Bangladesh. All of you are better placed to modify it according to people's psychology or whatever than I can. But this is how the steps work out in real life, if you want to follow the classical model. So and now final question. I wanted to leave cognitive bias at the last because it will take longer to explain. It's interesting. So cognitive bias is a very interesting thing. It's something that's fascinated me for some time. and I've done a bit of a research on it as well. So essentially, let me give you some example of cognitive biases. In America, they did some studies. A newspaper did a study. After, if you remember, after 9/11, they attacked Iraq on the presumption, or what the justification that Bush and Cheney gave is that Saddam Hussein was responsible for 9/11. Yeah, everybody remembers that. So then these newspaper people, they did a study. So essentially what they did is they wrote an article. In that article, they provided some evidence that will justify the invasion, and that suggests that Saddam Hussein was involved in 9/11. And then in that same article, they gave a few more evidence that suggests that Saddam Hussein was not involved in 9/11. So there are both kinds of evidence were in that paper. And then they chose, few readers. Some of the readers, before they gave them that paper, they assessed what was the belief of these readers. So in that group of readers, there are some readers who, before reading that paper, they used to believe that Saddam Hussein is responsible for 9/11. And then there was another group of readers amongst them who used to believe that Saddam Hussein is not responsible. And then they gave them that paper to read. And after giving them the paper to read, then they assessed their belief again. And interestingly, they found that people who used to believe that Saddam Hussein was responsible for 9/11, their belief was strengthened by reading the paper. Because what they did is they only highlighted those pieces of evidence that confirmed their belief. Whereas the pieces of evidence that was there, which suggested that Saddam Hussein was not responsible, they simply ignored it. And the other group did the opposite. So this is cognitive bias. You basically, trick your mind to find evidence which reinforces what is already there in your mind. So this is a big obstacle in our classical implementation of evidence-based medicine, because we do this. So I hope that clears you.
Yes, sir. Thank you very much.
I have a question.
Yeah. Dr. Sharmi, yes, please carry on.
Yes. From the informatics point of view, I'd like to know, do you think the clinical decision support systems and AI and machine learning, these are going to change the scenario of evidence-based medicine significantly?
Yes, yeah, I definitely do. And I think it will make life really easy, because the quality of clinical support decision-making, tools are really, really high. Definitely. I mean, there are other arguments for not using AI, but it is definitely, there are cases when they're even proven to be better than, because we make mistakes. Obviously you have to, the ethical argument is on a different scale, and you have to be careful as to how to implement it, but it will hugely improve things.
So are there any risk, or is there arguments on ethical issues going on? And people are talking about some risk factors as well of using AI in this sort of medical sciences. So do you think there are some risk factors in using AI and ML?
There are risk factors, but I think that's probably beyond the remit of the discussion that we are having here. I mean, that's a completely different ballgame, and the ethical argument against using it is quite a lot. So I probably wouldn't go there, but yeah, there are other risk factors associated with it. And the most important thing is, obviously, remember, AI in itself is not sentient, it's not clever. So it will only deal with, we have a saying, which is garbage in, garbage out. So your computerized decision-making tool will make a decision on the basis of what information you give it to him. So if you give, incorrect information or biased information, the result will also be biased. So that is the biggest risk, is that it will make a decision not on the basis of a comprehensive set of information, or not the quality of information may not be good. So that is the biggest risk.
Yeah, thank you. Thank you so much.
Okay.
Anybody else
Yes,
want to
sir.
ask any question to Dr. Munir Hussain?
Sir, can I?
Please introduce yourself and you can ask it.
Yes, sir. I'm Dr. Shahriar Mahmood. I'm working in the RCH department, BUHS. Sir, probably you're probably using it right now. It's something called BMJ best practice.
Mhm.
I'm not sure.
Yeah.
It summarizes the evidence that you are talking about, that doctors do not have the time, even the registrars do not have the time, let alone the consultants, wherever you work. So it helps summarizes things, but it's not available everywhere. Subscription based is a problem. Even what I have seen from my little experience is some doctors have access to these things, including the US version that's called UpToDate software. That also summarizes many of the available evidence, but not many doctors have the interest or time or whatever it is. So they are not going through it, one thing. But I have also seen a few doctors trying to use evidence-based medicine in their clinical practice. So it's not that it is non-existent. Thank you, sir.
Yeah. Okay. So that was a comment. Yeah. That's I thought BMJ had made BMJ best practice open for people from third world countries. I didn't realize the is subscription based. It's subscription based for us here, definitely, but I thought it was free for you guys. So I mean, it is what it is. They have to have their business, so I think some of the things they have to keep subscription based. But yeah, no, it's good to know that people are trying, so you have to do whatever you can. Okay, so if there are no more questions, because we are, we're beyond 1 hour, so shall we wrap up the session, Dala?
Yes, I think we can wrap up today's session. Thank you
So-
very much.
Okay,
Dr.
no, thank
Munir
you very
Hussain.
much for everybody for attending. Ami jeta bolte jacchilam Dala. So it's basically, as you know, this is really, I mean, not a teaching session. It's just a, exchange of ideas. I'm happy to have others and get some ideas about what's happening in Bangladesh about evidence-based. So there is not a lot to talk. I mean, we could have done it in one session, but I just kept it a second for tomorrow as well, to have a bit of discussion about critical appraisal, only if the attendees who are here, they want it. If you feel it might be helpful, then we can have another session. But you had a primary introduction to evidence-based medicine today, and if you think that's enough for you, then we can skip tomorrow's session. Mr. Pradeep Sengupta, what do you think, Dada?
Yeah, you asked a very good and interesting question. I think there should be another session tomorrow, and I believe most of our attendees also wish to join tomorrow. If there will be no accidental problem. So we would like to listen to you tomorrow also at the same time for 1 hour.
Okay, fine. So we meet in the same time tomorrow, inshallah.
Yeah.
Okay.
Thank
you so much.
Okay.
Thank you very much for attending today's session. And my special thanks to Dr. Munir Hussain for his nice deliberation, and we really enjoy today's talk. And hopefully we'll meet again tomorrow at the same time. And if you have any question, you can send him in advance in his email address. And otherwise you can ask at the end of the session. Thank you again. And Dr. Munir, have a nice day. and see you tomorrow.
Okay.
Okay, thank
Uh,
you.